There we go. And people are coming in. Welcome. And please join us for this 30 minutes with Lorimer Moseley as part of our master sessions and Lorimer's course in June 2024 in York. So thank you. Just have a seat, get yourself comfortable. Thank you, Los, for joining again. This is
G'day, Bart. Nice to see you.
Yeah, it's a great opportunity again to have a bit of a chat as part of. Also, we recorded as a part of the podcast we run, which go bi-weekly, and this will be released as an audio as well. And we are recording this session, so you can watch back as many times, and please share it with everyone you think would be interested. So as the numbers are still going up, but also aware of the timing, I think we just start this. And we proposed to elaborate and just to welcome you first. Thank you for the overwhelming response. We had over 2,000 people registering for this event, and great to see you all in live, and that's a good effort, depending on where you are. So please let us know where you are in the chat, so we get an idea. So Montreal, Canada, that's challenging for sure. So thank you. Today's discussion we'll delve in the nitty-gritty of a resolve trial, which is a trial that's been done, and what we've done so far is that Lorimer has been part of a group that has been creating a therapeutic approach that is called the fit for purpose model, if you like. It's used as a framework, and we will delve in that. We also give you some insights of how this paper, where it's released, and the backgrounds of it as far as we can go. And by the end of this webinar, I will give you a bit of a detail of the master sessions and NOI group course in which Lorimer will teach in Europe in June, and later that year, October, in the US and Canada. So please welcome, and Lorimer, I think we just start here to make the time as valuable as we can. So yeah, if you're right, to introduce some of the work you've been done on the resolve trial and the fit for purpose model.
Sure. Thanks, Bart. G'day, everyone. It's 40 degrees outside here where I live. I've just got out of the swimming pool, and I've just had a little bit of kangaroo to eat, and I thought that is about as stereotypically Australian as I could start this call with. But I'm sitting on Ghana land. It's a custom here in Australia to always acknowledge the custodial owners of the land whenever we meet in a situation like this. So I want to pay my respects to Ghana people and First Nations people. But thanks for the opportunity to talk a bit about the fit for purpose model, and I do wonder if it will become the fit model, because we're already adapting it to fit for performance, fit for play, but from the get-go, I really need to give a nod to Professor Ben Wand at Notre Dame University, who I've been collaborating with for decades, and he does a remarkable job teaching people how to become physiotherapists, and through that work, he's sort of at the cutting edge of the various developments in musculoskeletal pain, and he's a big part of putting the resolve care package together on the basis of the fit for purpose model that we sort of both have been working around and joined forces some years ago to say, well, we're doing very similar things here. Let's do them together. But the fit for purpose model, one reason that I'm excited about it, and I think that it's triggering a genuine excitement around the low back pain or the back pain field, is that it is a treatment approach that was generated from the ground up, and that contrasts with a lot of the treatments that we've used for chronic pain. Certainly that have come out of the psychological realm, where we've seen treatments that might work for something else, and we've adapted that to see if it works for chronic pain. Whereas the fit for purpose model really took a deep dive into understanding the pathologies that are associated with chronic pain, and that research work started in the late 90s. In our group, it started sort of around 2000, where we were identifying in the literature or in patients these consistent evidence across chronic pain states, actually, that various parts of the system were not working as they do in people who are not challenged by chronic pain. And we can sort of divide them up into three bits. And the last bit that has become known as a pillar of the fit for purpose model is the bit that the physical therapists among us will be most au fait with, and that really talks about the actual structural integrity of the body part. But I want to come back to that last, because the stuff that is from the ground up being applied now across chronic pain states are the other two pillars, and they sort of started to emerge 20, 25 years ago. And one we could summarize as a pillar that is about your conviction within your system that you are fit for purpose, that your body is actually fit for purpose. And there's a whole lot of data across multiple fields that tell us that a lot of people, most people with musculoskeletal pain, believe, understandably, that the painful body part is not fit for what you want it to do. That it's fragile, or it's vulnerable, or it doesn't work the right way, or it's unstable, or it's out of alignment, or it's not being moved properly, or your strategy is wrong. There's a belief, and that when we talk about belief, we really are trying to encompass multiple levels of your system. The top level of which is articulating, I believe my back is fragile. But we can also think about deeper levels of that, where the system is operating as though your back is fragile. So we could talk about, in the fit for purpose model, which has three pillars, the first pillar is about the conviction that your body is fit for purpose. The second pillar has been developed on the basis of a wide range of studies, and our research group's been at the forefront of this for some time, I think, identifying evidence that the maps of the body that are held within the brain are different. And we can talk about this in a few different ways. And when we get this across to health professionals within the context of, for example, a professional development course, or when we want a patient to understand this component, we might talk about the connection between your brain and your body, or how well your brain and your body talk to each other, or how accurately your brain has a representation or a map of your body. These sort of ideas, they're not normal in people with chronic pain. Those related to the back, they're not as we see them in people who are pain-free. And there's such a wide range of experiments that have revealed that. Some of them are clinical experiments, like looking at tactile acuity, so your sense of touch in the area, your movement commands, the motor control work of, for example, Paul Hodges, Michelle Sterling, Deb Fowler, some of the temporomandibular joint work, showing changes in cortical representation. So all of this big body of data that suggests that people with chronic pain, there is also a pillar in body maps that are consistent with the body not being fit for purpose. And the way that Ben Wand has labeled these pillars is really nice. The first pillar, we talk about you have a conviction or a belief that your body is not fit for purpose. Your body doesn't feel fit for purpose to you. And that's that second pillar. And and your bodily feelings come out of these brain representations. And there is a bit of work to understand that. So, you know, I'll obviously spend time on that when we've got a lot of time, so people really understand that. But the first pillar, your conviction that your body is not fit for purpose. The second pillar, it doesn't feel fit for purpose. And the third pillar is it's not fit for purpose. So these are the three pillars of the fit for purpose model, and they are a way of understanding chronic musculoskeletal pain states. And actually, we're currently working in non-musculoskeletal pain states, pelvic pain, abdominal pain, headaches, where the model still seems to fit. But we conceptualize the problem not as a single origin tissue pathology, not as a functional capacity inadequacy, not as a motor command disruption, but as an information processing and storage model. So then there's clear clinical treatment that come out of the fit for purpose model because they target each of those pillars. So if I was to try and summarize the fit for purpose model as quickly as Ben does, I would say it conceptualizes chronic pain as a problem of believing you're not fit for purpose, feeling like you're not fit for purpose, and not being fit for purpose. And they're the three targets of a complex care package.
So that makes a lot of sense. Like these summarize probably a lot would make sense for, I think, for physiotherapists, for doctors, and to some extent probably to psychologists as well, because it touches on all the details. So how this is similar or different to other approaches that are seen to be biopsychosocial, for example, like cognitive functional therapy or CBT?
Yeah. Well, see, I think most of the CBTs were adapted for example, mood disorders, depression, anxiety, phobias, post-traumatic stress, and have been cross-purposed to chronic pain. And the fit for purpose model, as I suggested, it has said, okay, well, let's start again. What's gone wrong in people with chronic pain, and how do we target those things? And there's a lot of data that we have to collect and analyze, over decades, actually, to be able to justify that. I think from a distance, one can certainly see similarities with cognitive functional therapy, which is also a multimodal treatment package designed from the ground up, if you like. And the similarities between the two approaches is that they both recognize a core pillar of reconceptualizing the problem and moving away from this idea of the problem being a structural pathology or a thinking deficit or a mood disorder, and move towards how someone is actually understanding the contributors and the cause of their chronic pain. So I think CFT, cognitive functional therapy, and Peter O'Sullivan has been the driver of that. I recognise other people are also doing that. A lot of people are learning off Peter and others how to do that. But my understanding, and from talking with Pete, is that changing your understanding of the problem is key. And that's also key within the fit for purpose model and the resolve treatment, which is based on the fit for purpose model. Where it's different, I think, is certainly in that second pillar. What the fit for purpose model suggests is that these changes in how the brain represents the body and this sort of body-brain connectivity is part of the problem. And the model takes a very neurocentric or neuroimmune-centric approach to understanding that, based on the principles of how neural networks operate. And if anyone's done one of the master sessions that I've done, we spent a fair bit of time on this idea of neurotags. And that's not part of the concept nor the intervention, I think, within cognitive functional therapy. And the link between these three pillars in the fit for purpose model is probably the thing that most obviously differentiates it from, say, CFT, where educational science drives the reconceptualization. And there's a massive amount of data in educational science about how do people learn things in order to operationalize them, in order to think differently. How do we help things stick? How do we target the right concepts, and what are the right concepts, and what do recovered consumers tell us we should do? Those sorts of things have been very informative in the fit for purpose model. The last pillar, which is about ensuring the body is fit for purpose, I think the resolve treatment and the other treatments that have come off the fit for purpose model probably take a more conservative or a conventional approach to increasing the physical capacity of the body through delivering appropriate stimulus for change that's informed by physiology, our current understanding of overload principles, and hugging on to one of my favorite and most reliable principles of biology, which is the sweet zone for change. And this idea that the body will change if we get the exposure right. The other model that I think is relevant here is the work that Howard Schubner is doing in North America around pain reprocessing therapy. And pain education, or explain pain, is a core pillar of that as well. And it's a very exciting time for back pain, and my prediction is for the other musculoskeletal pain. So we've got half a dozen big clinical trials running at the moment at various stages, basically implementing fit for purpose based care. But each of these new treatments in clinical trials clearly show benefit over their control. They use different controls, and that's really important. But they're all built from the ground up, and the mechanism of effect, at least in two of those, in what we do and in what pain reprocessing therapy does, we've looked at how does it work? What are the mediating mechanisms? And a big chunk of the improvement in pain disability is explained by reconceptualization of the problem. And I think it's really pushed me and others in this space to think, wow, this is really important. Getting a shift in understanding is really important. More important than we thought it was when we started doing Explain Pain. It's just that we've realized over the last 20 years that we weren't very good at getting a shift in understanding. And we're still not excellent, but we're getting better at it.
So you guys have been working for a couple of years now on a big trial, like other approaches also been tested. And I think you already mentioned the Resolve trial. So that's a clinical trial. So could you briefly highlight or a little dive into why this trial and why is it important to know about this?
Oh yeah, I love the Resolve trial. I think it was beautifully planned, rigorously prepared. James McCauley at Neuro in Sydney is a clinical trialist who was in charge of that trial. Ben was in charge of putting the pillars into a treatment that we could test in a clinical trial. So whenever you're doing a clinical trial, it's not exactly as you would deliver it in real life, right? But you have to standardize it in order to test it. And for us, in order to compare it to another standardized treatment. And one of the reasons I love it is because I've felt for a while that if we do a clinical trial of any back pain intervention, for people with chronic back pain, they'll improve. It's almost no matter what we do, they'll improve. All the data tell us they'll improve. But we haven't been able to find a treatment that shows clearly an improvement that's better than all its non-specific effects, which leaves the whispering in my mind of, so is this just a different way of packaging non-specific effects? So we were very intentional about having a control group in the Resolve trial, a control group that we worked out beforehand. When people are engaged in this treatment, we've been treating clinically along these lines for a decade. When people engage in this treatment, what do they love about it? And one of the things they love is that it involves the brain. So we thought in our control group, we have to capture that excitement, the brain. What else do they like? The connection with a therapist. Okay, we have to control for that. What else do they like? Having multiple components and being able to do things at home. So we put possibly more care to establish the sham intervention. Because what we wanted to know is it the learning, the refining of the neural maps and the graded movement and loading that make the difference? So in a way, none of us really thought that this trial would have a positive result. What we were hoping for was that it would tell us what are the predictors of a positive result. But when the trial, it's very conservatively planned, and the statistics were very conservatively planned, and we had this phrase as we were planning it and doing it, that we were saying, we are making the Resolve treatment work really hard to show some love, if that makes sense. We're comparing it to a really challenging comparison group, and it showed a benefit over that comparison group. And when we dive deeper on the data, that benefit is really exciting. There were the median outcome, so that's the middle result of all of the results, was recovery. Like, it's amazing. We just don't see this in chronic back pain. So the Resolve treatment, I'll talk a lot about the Resolve treatment at these courses and how we did it and how we're already adapting. It's already evolving. Our education offerings are way better than they were 6 years ago when we started the Resolve trial. But the treatment package that clearly targets those three pillars, shows benefits on the three pillars, but importantly, shows pain and disability and recovery and health use benefits, compared to an equally compelling, equally credible, equally exciting, and equally time-consuming control intervention. Anyway, it's hard to summarize it quickly, right? But I'm a believer. Not that we found the answer. I don't think we found the answer. But that we have taken a significant step towards a really high impact shift in care. And that's exciting. It's really exciting to be a part of that.
Well, I can imagine that. And as well as in the data, like you suggested, that probably the clinical one-on-one, the framework probably will allow therapists to create a true biopsychosocial approach that is offered new directions, as well as you will dive deeper during the course, obviously. And I think that will be quite a different course than you would teach or taught 10 years ago. Is that right?
Oh, yeah, for sure. There's some things that have stayed true, right? But the beauty of being a scientist is that you're expected to update. When you realize your hypothesis doesn't cover everything or your theory is not quite right. But I look at how we're now thinking about the pain education component compared to 5 years ago. Very different. And I've got to pay tribute to Dave Butler in influencing my own journey on that, because he has been relentless at saying, what do the educationists say? What do the educationists say? And I've been relentless in saying, what do the recovered consumers say? And between us, I think we're onto something really good. And it's not just Dave and I. It's a whole team. Ben and then people in different groups around the world. Interested people could check out the PETAL website. PETAL stands for Pain Education Team of Absolute Legends. And that'll give you an idea of the people who are really engaged in pushing for pain education that changes understanding. And we don't use that PETAL words in papers. We say pain education team to advance learning. But But I think all those people doing it, they're absolute legends.
Well, yeah, but people will remember the first. I reckon.
Yeah.
The absolute
You go to
legends.
Petal, search Petal collaboration, and you'll find it. Have a look at
Obviously. Oh,
what
that's
stuff
great.
we're working on.
Yeah. So to summarize, Lars, and I think this is really exciting. So we can move on with some other conversations. And during the course, I want to highlight the dates, at least from the first course that will happen 14-15 June in New York, the UK. There will be course booked later in that month in both Valencia and Vienna, and we're waiting for some confirmation. But if you're interested, just give us an email so we can make sure you're on the waiting list, and we'll send you or forward you to the organizations that take care of these courses, as well as the US, San Francisco, help me, New York.
Yeah, no, well, actually Vancouver.
Vancouver, yeah.
Yeah, and then we go to so that's at the end of September, and then we go to the southern states of Canada, like California. Obviously not Canada. We go to San Francisco and then New York City. Yeah, that's in October.
Awesome. Yeah, that's. I think it's pretty nice to get back face to face, because I think we missed that a bit, or a bit more than we thought. As we love to see.
I haven't been to North America for, I think, 5 years.
Yeah,
Oh, a long time. Can't wait.
Can't wait. So that needs a big catch up for sure. Yeah, just have a look at our website, mastersessions.academy, or just sign up for to keep updated. We've recorded this session, and we will also publish it as a podcast on our Master Sessions podcast. So if you're interested in the USA and Canada courses, please go to neugroup.com, because they will hosting those courses. For the European courses, you will find mastersessions.academy, but we will notify you. We've got your email address, and we'll make sure we'll let you know about the details. Yeah, this is exciting times again, and it's good to see each other in the flesh again. There's lots to share there, Lars, and lots to celebrate.
Yeah,
like
no,
it's exciting.
It's going to be cool. Like, I haven't even touched on the virtual reality stuff, which is just very cool. The neuroimmune development, the books. Oh, it's been fun. Anyway, it's going to be great. Come
For sure. All right, so going to wrap this up. Thank you for turning up live, because that's a massive effort, everyone. Thank you so much for taking that effort. We're looking forward to hear from you back again. Thank you. Have a great day, or night, or morning, whatever. Take care, and see ya.
See you, folks.